Hello, everyone. My name is Kendra Denike. I'm from the Japan Society of Northern California, and I just wanted to welcome you all to the digital transformation of healthcare, hospitals at home, and remote patient monitoring. Before we begin our program today, we have a really quick tutorial. We have an AI translator, and Mr. Chris Hargett, the head of marketing from Wordly Inc., can share a little bit more about that with you. So take it away, Mr. Hargett.
Thank you so much. Okay, so it's pretty straightforward, and we have the instructions in English and then again in Japanese. So you'll notice in the top left corner of Zoom, you have a red button that says Live. And if you click on the down arrow, you can open up a menu that allows you to click on View Stream on Live Custom Streaming Service. And if you click on that, that will open up in your browser a window that lets you see a transcript of everything being said. And then you can click on the default language to choose from a menu of languages your preferred language to read a transcript of everything the speakers are saying in today in the Zoom call. And let me repeat that and it works on most browsers, most modern browsers. And we recommend that you kind of resize that window so that it's off to the side so you can see the transcript and any video content that's being shown at the same time. And then let me. And that should do it. I hope that's helpful. Please chat me directly if you have any questions.
Thank you so much. We're really grateful that Wordly was able to donate their service to this event. Okay, so now let's get on to the program. I'll be turning it over to Mr. Takehide Akiyama for opening remarks. He is the president of the Japan Society of Northern California.
Thank you, Kendra. Good evening or good morning to you. I'm Takehide Akiyama, president of the Japan Society of Northern California. On behalf of the US-Japan MedTech Frontiers and Japan Society of Northern California, I would like to extend a warm welcome to you all. Today's event, together with day 2 on May 19th, is the second event following our inaugural event last October, where we introduced 22 very interesting US startup companies in the medical device area. US-Japan MedTech Frontier was established in Silicon Valley in 2013 by a group of medical professionals, including its chairman, Jack Mormon, and Dr. Fumiaki Ikeno of Stanford University, Wilson Sonsini, Goodrich and Rosati, and Masa Ishii of Asuka Ventures. USJMF created an annual series of highly successful events held in Japan each year until the pandemic. The Japan Society of Northern California is a 116-year-old organization based in San Francisco and committed to advance understanding and friendship between the US and Japan. It holds a variety of events throughout the year in arts and culture, and technology, innovation, business, and many more. The two organizations are different, of course, but have something in common. That is a passion to connect the people from the US with people in Japan. The fundamental idea is to find areas of common interest and facilitate discussions and meetings around those areas of common interest. The program today centers on common interest of healthcare in a changing world. The current system in the US, Japan, and other countries as well are not sustainable due to a combination of disease, cost, and aging population. One possible solution is to take digital transformation that has taken place in other areas and apply it to healthcare. The application of IoT, the cloud, edge computing, machine learning, deep learning, the internet sensors and other devices and software holds the promise of better outcomes, higher patient satisfaction, and lower cost. To some of you, these ideas of hospital at home and remote patient monitoring and treatment are well known, but there are some to whom this is all very new. We have asked 6 speakers today to give you their view of the new ideas. After the presentations, Dr. Ikeno will moderate a joint discussion. Following that, we invite you all to a networking session where you can discuss with our speakers, our MedTech experts, and each other. Following this, on day 2 in May, we will introduce to you 8 to 10 unique startup companies who are developing cutting-edge technologies to advance hospitals at home and remote monitoring. Taking this opportunity, I would like to thank sponsors and supporters of this event. You are now seeing, I hope, their names on the screen, and we are very grateful to their general support. Thank you very, very much. In these difficult and challenging times, the need for advancing healthcare has never been greater. It is a sincere hope that this online event can help enhance understanding and the collaboration between the US and Japan in the development of digitization of healthcare. Now I'd like to introduce our first speaker today, Dr. Fumiaki Ikeno. He's Medical Director, Research Associate, Experimental Interventional Laboratory Division of Cardiology of Stanford University, and the Program Director of Biodesign Japan, Stanford Biodesign Program. He's also extensively involved in research and development and the clinical studies of many medical device startups, and is working diligently to establish a Silicon Valley-like ecosystem, medical device ecosystem in Japan. He's an appointed member of the Advisory Committee on Medical Device and Healthcare of Prime Minister's Office of Japan. So ladies and gentlemen, please welcome Dr. Fumiaki Ikeno.
Good morning and hello everybody. My name is Fumiaki Ikeno and I am the co-founder of US-Japan MedTech Frontier. Thank you very much for joining us again this year. Before today's keynote speeches by excellent invited speakers, I would like to make a general presentation on healthcare's digital transformation. This slide is a futuristic illustration of what medicine of the future will look like or want to look like, shown in 1924, about 100 years ago. You can see that the patient is at home and the doctor and the nurse are examining and treating the patient from a remote location via radio communication. This slide shows almost the same concept as the previous one, but with the fancy that the patient can see the doctor through a telephone line and also through a monitor. In the 1960s, NASA began to think realistically about providing health care for astronauts between space and the ground, and the project officially began. Here is a history of telemedicine in the United States. In 1959, at the University of Nebraska, doctors used interactive telemedicine to send neurological examinations. In 1967, an interactive network between Logan International Airport and Massachusetts General Hospital, both in Boston, was established to treat patients with a two-way microwave audio and visual connection 24 hours, 7 days at the airport. In 1975, the space technology applied to rural area healthcare program was developed and funded by the federal government. This program provided the remote area in Arizona with the same telemedicine technology that was used by NASA for astronauts. In 1989, the heart attack patient was successfully defibrillated by telephone in St. Louis. In 2007, Apple launched iPhone. President Obama took office and vowed to spec digital technologies to halt the rising cost of healthcare in the United States. And COVID-19, which began last year, is accelerating telemedicine at a rapid pace. In the United States, the total number of infected patients was exceeded 30 million, meaning that almost 10% of the population has been infected. With over 560,000 deaths, it is the third leading cause of death after heart disease and cancer.
It is the same all over the world. The more extensive the pain point, the more grateful we are for ways to solve it. In that sense, the most significant pain point in the United States today is the COVID-19. And we must have a way to solve the limitation caused by COVID-19 around the time in our medical care, economy, and lives.
Earlier, I traced the history of telemedicine back 100 years. Still, in the last 30 years, the evolution of digital technology has gone through the roof, and with it, the expansion of telemedicine into something feasible has been very significant. However, as of 2019, before COVID-19, telemedicine penetration in the United States was at best a few %. However, in 2020, with COVID-19, telemedicine will spread quickly and unavoidably. And in a sense, telemedicine's social value has changed to something that must have to solve a pain point. The graph here shows the outpatient consultation patterns in March and April of last year. Yellow is for regular face-to-face consultation, and gray is for video consultation for chronic disease. The purple color is the video consultation of acute illness. As you can see here, before the lockdown, almost 100% of chronic disease were examined face-to-face, and some acute conditions such as stroke were treated remotely for initial response. Immediately after lockdown, the total number of hospital visits dropped rapidly. The breakdown shows that telemedicine rapidly spread chronic disease and replaced face-to-face care. The number of acute conditions also increased, but this was primarily due to COVID-19. The graph here also shows the number of patients and doctors per day using telemedicine. We can see here as well that both are increasing rapidly right after the lockdown. As you can see, even before the COVID-19, telemedicine was already in a situation where it could be used at any time due to the elevation of digital technology, but it has not yet become widespread. When the COVID-19 pandemic came, the need for telemedicine suddenly became urgent and serious, and it became widespread. The year 2020 was marked in human history as the year of the once-in-a-century pandemic caused by COVID-19. But it may also be marked as the first year of telemedicine with digital technology. What are the other pain points in the United States? It is the ever-rising cost of healthcare. This graph shows a comparison of medical costs between Japan and the United States. The US far surpasses Japan in terms of healthcare expenditure per GDP. The absolute number of healthcare expenditures and healthcare expenditure per capita, with the United States being the most in the world in all of these areas. One of the manifestos of President Barack Obama, who took office in 2009, was to make health insurance available to all citizens. Still, at the same time, it is clear that he was worried about how to control the rapidly increasing cost of healthcare. The United States health insurance system is very different from that of Japan. About 56% of the population is covered by private insurance, 35% by public insurance for the elderly, low-income people, and veterans, and still 9% of the population is uninsured. I mentioned earlier that 35% of the population is covered by public insurance, but on a monetary basis, public healthcare costs account for about 44%, and the private insurance costs are almost the same amount. Therefore, the United States is dominated by private insurance companies, but on a monetary basis, private and public insurance are practically equal, indicating that there is a great deal of pressure on public spending. In particular, readmission for acute exacerbation of chronic heart failure accounts for a large portion of expenditures. 1 in 2 patients with chronic heart failure is readmitted within 6 months of discharge from the hospital, with 42% of readmission attributed to poor management of heart failure at home after discharge, including inadequate medication and lifestyle management. In fiscal year 2021, CMS will penalize 2,545 hospitals for having too many Medicare patients readmitted within 30 days, according to federal data cited by Kaiser Health News. This is the 9th year of the hospital readmission reduction program. To determine penalty for fiscal 2021, CMS examined hospital's 30-day readmission rate for patients who had originally been treated for the following conditions: heart failure, heart attack, pneumonia, chronic obstructive pulmonary disease, hip or knee replacement, and coronary artery bypass graft surgery. Hospitals penalized by CMS will see their reimbursement prices reduced by public insurance, and their reputation for poor quality will result in fewer patients and, the worst scenario, possible bankruptcy. Therefore, it has become a matter of life and death for hospitals how to monitor heart failure patients after discharge from the hospital, identify patients with a tendency to deteriorate in advance, and take preventive measures to prevent deterioration. As shown in the figure, monitoring and analyzing vital signs at home is now possible using wearable devices and smartphones, connecting hospital and home, and doctor and patient. Will the digitalization of these medical services slow down rapidly after the COVID-19, or will continue on a parallel track, or will it continue to evolve the spread? My personal view is that it will spread further. At the end of last year, CMS announced a comprehensive strategy to enhance hospital capacity amid the COVID-19 surge. The first is to provide the same kind of care at home as in an acute care hospital. And 6 groups were approved as of November 25 last year. The second is to allow more flexibility in ambulatory surgery. This means that the so-called virtual hospital concept, previously thought to be scientific fiction, has become a reality. Trends at CMS, which controls public insurance in the United States, are essential because private insurance companies, which account for just under half of U.S. healthcare spending in monetary terms, use CMS as a reference in determining reimbursement. Looking back on last year, department stores were replaced by online shopping as represented by Amazon due to the effect of the pandemic. Restaurants could be enjoyed at home by Uber Eats. Movies could be enjoyed at home without going to the cinema by Netflix. And commuting to work became possible by Zoom. Zoom has made it possible to work from home, which has led to the rapid spread of the home-based lifestyle. In the medical field as well, it has become more and more desirable to receive medical care at home. And let's take a look at Japan. What are the current pain points in Japan? This slide shows the evidence of infrastructure and also healthcare providers number in Japan and the US. The number of doctors and nurses are almost same between two countries. Japan has by far the largest number of hospitals per capita, with about 4 times as many per capita as the population. In the United States, the number of public hospitals is 2.7 times that of private hospitals, indicating that Japan is dominated by private hospitals, while the US is dominated by public hospitals. The number of acute care beds per capita in Japan is 3 times that of the United States. The length of hospital stay is more than 3 times as long, and the number of annual visits to clinic is more than 3 times that of the United States. Overall, the number of healthcare providers per acute care bed is much less in Japan. This fact should be a negative factor for COVID-19 care. These exist a social problem that the medical profession is exhausted. In summary, Japan's medical system has more hospitals than that of the United States, but many of them are private hospitals. Compared with countries like the United States, where public hospitals predominate, it is difficult for the government to intervene in such areas as COVID-19 control beds, leading to a shortage of COVID-19 capable beds. However, there is a large number of medical equipment, such as MRI and CT, for diagnosis. Besides, the length of hospitalization and the number of medical visits are also prominent. This is probably due to the benefit of universal health insurance system and free access to medical care, and the relatively low cost of medical care compared to the United States. However, human resources are serious, and the number of doctors and nurses in acute care bed is relatively tiny. The exhaustion of medical professionals has become a problem during this pandemic. Another pain point of Japan is advanced aging society. Most of the current social welfare programs and policies were created in the 60s through 80s. As you can see here, the age distribution was very different back then. The working age population accounted for much larger portion of the population. The age distribution profile has changed substantially last several decades, and Japan has become the most rapidly aging country in the world. The shift impacted social welfare programs significantly, less working forces for more benefit recipients. Japan has had a world-class universal health insurance system since 1960. However, no one is sure whether this system can be maintained forever in the 21st century when the demographic structure has changed compared to 1960. I was born and raised in Japan. After my medical school and residency, I worked as a general physician at a small hospital in rural area. It was a very small town like this. The aging rate of the town where I was working was already 40% 20 years ago. In 30 years, the entire Japan will be like the town I was working. If I go back to Japan to begin my medical practice again, it would be like the movie Back to the Future. I experienced lots of issues in the advanced aging community 20 years ago. For example, many elderly people in the town were living alone or taking care of their elderly spouse, bedridden and or demented. The most serious issue is a shortage of caregivers, social workers, nursing homes, and family support. In general, there are multiple solutions to a single problem, and it is crucial to choose and combine them well from time to time. How to solve the problem? Learn from the United States. Can digital transformation of healthcare be one of solutions of problems in Japan? We have to create our future by ourselves. However, I think it is essential to refer to the examples of countries that are making progress. Today, I would like to invite 5 speakers to give keynote speeches on healthcare's digital transformation. Mr. Raphael Rakowsk, CEO of Medically Home, provides hospital-like care in the home. Mr. Amar Kendale, Chief Product Officer of Teladoc Health, which is the nation's largest telemedicine service providers. And Mr. Bakul Patel, Director of the F.D.A.'s Digital Health Division. And my mentor and role model, Dr. Peter Fitzgerald, Professor Emeritus at Stanford University. And from Japan, Mr. Zaif Siddiqi, Global Head of 5G and IoT at NTT Docomo. Let's learn from 5 inspiring keynote presentations. And in about a month, on May 20th, we will be introducing 9 starting apps in telemedicine, mainly from Silicon Valley. Finally, we are having these conferences because we want to save the patient all over the world through collaboration between Japan and the United States. Of course, it is important to learn each other's know-how, but knowing who is even more crucial. Like last year, the conference will be online, but we will have a digital networking opportunity after the lectures, both today and a month from now. We hope you will join us. Thank you very much for the patience.
Thank you so much, Dr. Ikeno. Now I'm going to turn it over to Mr. Bakul Patel, Director of director at the Digital Health Center of Excellence of the U.S. Food and Drug Administration's FDA Center for Devices and Radiologic Health, CDRH.
Hello, my name is Bakul Patel. I'm the Director for Digital Health Center of Excellence at the Food and Drug Administration in the Center for Devices and Radiological Health. Today, I'm going to share with you what we are seeing as far as trends goes in the space, what we're doing with it, and where we are going with it. Digital health is a convergence of connectivity, data, computing power for healthcare, and its related uses across the life of an individual or of a patient. What this offers to us is a really unique way of looking at healthcare, where technology is now moving care from the clinic to the patients. It has the opportunity to show us how patients and persons are actually behaving or actually operating in their natural environment. And this technology also provides this opportunity for us to start looking at what preventions opportunities, what earlier and smaller interventions have opportunities that can potentially be leveraged as we start understanding more about the person or the patient. All this is probably possible through the computing power and software that's now existing today. Just to give you a glimpse of what is in the store for us, some have predicted that gamification-based wellness is going to be a common thing. We are going to see many more implantable products that will probably be part of our life. And we start saying various things such as our insurance are going to be very digital, robotic nurse assistants, and all those futuristic technologies can potentially happen. And as you can see from this illustration, some of this is already underway. But as you start thinking about the specific world of moving healthcare from the clinic to the patient, we really think that wearables and things that we carry in our pockets, such as smartphones and watches, can really tell and give really big insights into how a person or an individual is actually performing in the normal routine life. As we start thinking about these solutions, we can also start thinking about what are the different questions a regulator or the healthcare ecosystem should be asking. Digital health tools can provide consumers with valuable health information. But then we have this opposite question of what types of technologies should people trust, which means that what qualifies as products that should be regulated so there is evidence. What can consumers be best informed about their health so their lifestyle can actually be changed? But then the question sort of draws between, from a regulator's perspective, is where does the consumer health product stop and where does the digital health product start in the space? But I believe that there is a continuum that happens in this entire ecosystem where we can start leveraging opportunities for healthier lifestyle, as well as potentially looking at some unique evidence-based solutions that can actually help healthcare. Having said that, digital health is becoming a feature at every point of products that we are regulating as a regulator, as F.D.A. and other regulators in the world. We are seeing products that span across the lifestyle of a patient or an individual, but we're also seeing products that are becoming that are coming in as a medical product. We're also seeing things that are incorporated into medical products. And it's not surprising to see manufacturing or making of those medical products also has digital health technologies. You can also see, I mean, it is as obvious as decentralized clinical trials are becoming much more common or much more desired. Digital health solutions, consumer technologies are becoming a leveraging tool for us to gain efficiencies in how we study products. As we move forward into this realm, we're also starting to see how digital health solutions technologies, software, and apps can start becoming much more additive to our current therapeutics or diagnostic solutions. Having said that, since 2010 onwards, we've been on this journey at Center for Devices and Radiological Health, where we are saying it's really about the functionality that matters, but it has to be risk-based. It has to be tailored narrowly, so all resources are appropriately used. So we can start focusing on protecting patient safety, promoting patient engagement, and making sure that our innovation is promoted while we are staying independent from the platform. With that in mind, we have been publishing many guidances, and from very different angles. We published our very first guidance on mobile medical apps, addressing the mobile medical applications that have been emerging in the field of smartphones. And then we went on to starting to discuss software as a medical device. We started to discuss general wellness products, and so on. The situation is rapidly evolving. We know that product development timeline in digital health or software specifically is much more quicker than traditional hardware-based products. We also know there's plenty of opportunities in post-market data that will help us gain better insights into benefits and risk than just adverse events. On the last point, I want to make that the volume and the number of people exploring and the ease of making these products is driving many more innovators, many more developers, many more manufacturers to create digital health solutions. And those solutions, when regulated, needs to be regulated in a very proper way, which means that we need to think about how does our regulatory processes can sort of adapt to those requirements of needs and resources. As we start looking into this, we are looking at how do we foster great digital health innovation that encourages development, but also at the same time ensures safety and effectiveness, while keeping in mind we really want these products to be in patients' hand as fast as they can, in the best possible with the highest quality that is possible for these products. I would emphasize that our current regulatory structure may not be optimal for those newer technology challenges. So we started imagining and understanding what could we do, and here's what we've been doing for the last 3-4 years. 2017, we said, let's imagine a world where we can trust and verify an organization's ability to make products consistently in a safe and effective way that gives confidence to both users and regulators. So if you think about that and take that vision one step further, imagine a situation where we have, as a regulator, continuous assurance of products to be safe and effective by understanding what the organization's performance is, as well as the product's performance is. When you combine those two things to these objectives we have, how do we keep providing reasonable assurance of safety and effectiveness, improve time to market for this product so patients can have access to this high quality products? Can we improve our experience to those people who are seeking market authorizations from FDA? And how can FDA reviewers get better experience while we're keeping the least burdensome concepts in front of us? So if you were to move from an episodic oversight to a continuous oversight that enables trust in an organization with a pragmatic check-in with real-world organization and product performance, we believe we can come up with a solution that will actually help us move forward and allow organizations and companies to make great products. We started off with these principles. We started off with these 5 fundamental principles that is embodied in our current regulations, and we feel they are the foundation for everything that we are doing. We have added one special thing here, which is cybersecurity responsibility. I mean, patient safety, product quality, clinical responsibilities are given. Proactive culture is also given. But I feel that with digital health and as connectivity improves, we want to make sure that all of our products that we are creating and using are resilient to cybersecurity threats. Since 2017, we've been developing this program. And we have taken plenty of steps to advance the development of this program. In 2017, we announced the program and selected few participants to help us understand how modern software development happens, how organization excellence can be used. In 2018, we further built this concept, and in 2019, we published a working model that we were using to develop this program. Since then, in 2020, and the public health emergency, we have started looking at all the information we have collected so far and to test some least burdensome approaches to help us further develop this program. We are on a verge to start simulating scenarios to see how we can determine some interdependencies and uncover some unknowns to build the program. We are on this process of understanding how this program as a whole can fit together. So bringing it back to a timeline, we have been working towards how do you create an in silico model, build this simulation scenarios that we can actually look at what are some dependencies. We can understand what are some gaps in our current regulations, and we want to continue to work with those stakeholders to gather current practices and to develop a plan for beta testing. In parallel, in 2019, we also published a machine learning and AI framework. We wanted to allow frequent iterations for this amazing technology to be available. At the same time, we wanted to make sure the performance of these products are improving over time and not just learning for the sake of learning and potentially even degrading. We feel like this technology, this way of using artificial intelligence and machine learning can truly hold the potential for advancing healthcare and create better standards of care. The model we published was this. We said there are 4 points in the entire life cycle of a machine learning program where F.D.A. oversight, or at least understanding of what those expectations should be for makers of those products, would be helpful for us to provide a total product lifecycle way of overseeing it and moving really away from the episodic methods of just looking at the product, as I talked before. Now, truly, this model or this approach is a use case of the pre-certification program, where we are not only looking at the product's performance, but we're also looking at capabilities of the makers of the products and the good practices that go into it, as well as the real world performance of those products. Over the last few years, we've been slowly making our way towards what should we be doing next in the AI ML space. Recently, we published an action plan, which takes a holistic approach towards how do we take the AML proposed framework and advance it. How do we advance standardizations or standards development in the good machine learning practices, and then really look at how do we start looking at patient-centered approach, including diversity in the data set and considerations that will actually bring this technology to fruition, and actually we can take advantage of that. Having said that, to fast forward, I would say that we need a better way to be coordinated. And the best way to be coordinated is to start creating a platform where we can create an opportunity for people to have a conversation within F.D.A. and outside of F.D.A. to start thinking about this cross-cutting topics such as digital health, software, wearables, and other topics. With that in mind, late last year, we announced the Digital Health Center of Excellence. The goal for the Center of Excellence has been to empower stakeholders to advance healthcare by fostering responsible and high-quality innovation. What I mean by that is the center will actually help to build and connect partnerships to accelerate digital health advancements. We also want to create a place where the regulatory knowledge can be shared within the agency. We also want to make sure that just like I described earlier about how do we create opportunities for us to start thinking about new regulatory approaches. How can we experiment? What approaches work, what doesn't work? Can we create a truly learning regulatory environment is really what we're looking for. As we move forward, we need to build this center of excellence further. We are currently focusing on these functional areas of the center. Not only we are trying to provide support from both regulatory policy and technology, but also we're trying to advance regulatory science, we're also trying to advance manufacturing aspects that uses digital health technologies. We're also looking to see how best we can further topics such as security, device security, as well as AI/ML products that we are regulating, or we want to make sure that they're developed in the best way. We anticipate the outcomes for the Center of Excellence to be to strategically advance science and evidence-based digital health technologies. And not to read everything on the slide, but I want to make sure that one thing is highlighted is we want to make sure that consistent applications of policy across CDRH is maintained. We also want to make sure that people at FDA are also growing and understanding how these technologies are being used, operated, and implemented in real life. With that in mind, we are also building specialized expertise within the Center of Excellence. I want to share a couple items on what we have done during the pandemic. We have authorized a few dozens of emergency use authorizations for digital health products that includes in vitro diagnostics and non-in vitro diagnostic products that predicted or used as screening tools. We published guidances that allowed for the agility required for remote care. Having said that, meanwhile, our review divisions have been busy authorizing novel technologies. Here's a couple of examples of those. Here's on the right-hand side, you see a see-through surgery virtual reality platform that help surgeons augment their surgery experience. On a larger scale, I wanted to draw your attention to a couple notable authorizations that FDA has provided. As of September 2020, we saw 4 major players that are empowering millions of individuals across the globe to be empowered to start looking at their heart health or being aware of that. This is the true patient-centeredness is really what we're excited about. We are also seeing technologies such as cognitive behavioral therapy that's helping people with some insomnia and treating people with substance abuse disorder and other chronic diseases such as diabetes. Late last year, we also authorized the first game-based digital therapeutic to improve attention function in children with ADHD. We're also starting to see a rise in AI and machine learning products that are, and an example of that is here at the bottom right, which talks about automatically detecting more than mild diabetic retinopathy in adults diagnosed with diabetes. As we see these exciting applications that are coming to FDA, we see a lot more happening in the future. We are seeing investment growing at about 25% compounded annual growth rate. And some research is predicting 500 billion investments in this space. Although we have accomplished a ton over the last few years, we feel like the expectation for digital health post-COVID or right now is going to be increasing beyond these projections. I also think that FDA will continue to adapt, and we will adapt, so we can increase and improve our expertise, policies, and oversight. I want to conclude today's talk with this one last statement. FDA is excited to foster evidence-based safe innovation for a better healthcare system where we can work together, reach all patients for better treatment and outcomes for all. You can reach us at this email address at digitalhealth@fda.hhs.gov or visit our website at fda.gov/digitalhealth. Thank you very much for your time and thank you for the opportunity.
Thank you, Mr. Patel. Our next speaker is Peter Fitzgerald. He is an Emeritus Professor of Medicine and Engineering at Stanford University School of Medicine and the co-founder and managing partner at TriVentures.
Well, good morning or good afternoon or good evening. It's a sunny Sunday in California this afternoon, and get the honor of discussing with you some of the massive changes that have occurred in healthcare in the last 2 to 4 years. The digitization of medicine has really brought us into, in an accelerated fashion, a new era of healthcare. And I'd like to discuss a little bit of what we see from Silicon Valley, but also since digital medicine is borderless, you don't just get it approved in Europe and then the United States and then in Japan. It becomes something that can be used globally. And in this era of 2020, having something that works globally is an important issue because we have lived through a unique forcing function that's made us think a little bit different. And I'd like to share with you a book called Think Again. It's by a gentleman named Adam Grant who wrote the book with Sheryl Sandberg, Option B, a few years ago. And this really talks about if knowledge is power, then knowing what we don't know is wisdom, and making mistakes and admitting it is a powerful way to learn. If you just think the same way and expect different results, it just won't work. And we've learned this through a forcing function called Corona this year. We can do things differently if we rethink the situation. So I'm proposing not only to have you read the book, but let's rethink about healthcare, because that's important. Today, the pharma and biotech focus is on two ends of the spectrum. Specialty pharma. Why? Because these are very expensive drugs to patients. And on the other side, oncology, because the bar for the FDA is low. So as a result, we see a discrepancy as they get applied to our healthcare system. And we're seeing a big gradient between what patients can afford and what hospitals need to charge. Cost of drugs have gone up, the co-pays for patients have gone down, and the premiums for those same people have gone up. 41% of all people in the United States, and this may not affect us in the room here, but 41% of folks in the United States become destitute after 16 to 18 months of cancer therapy. And I don't want to pick on a particular company or a particular drug, but the last medication that was approved in November 2020 for an unfortunate pediatric disease called progeria, or an accumulation of proteins appear in your cells and you kind of age very quickly. And you live to about 17 or 18 months. But the label for this medication is able to be implemented to these young children from 6 months all the way to when they leave us, 17 or 18 years. But it's $90,000 for a 30-day prescription. So ladies and gentlemen, in the United States, we're bending the curve the wrong direction. We spend more for healthcare, and we have a decreased expectancy, life expectancy, compared to many, many other folks throughout the country. As we usher in, though, the digitization of medicine, we begin to think differently, from rules-based heuristic care to probabilistic data-driven care, by understanding not only the spatial data, but the temporal data over time, so we can participate better in the journey of a patient in healthcare. But being able to have digitization transform this global healthcare, it's much broader than the bimodal distribution that we saw for pharma or for biotech. This is much broader. It has components of preventative care, wellness and fitness. And for some of those unfortunate people that have chronic diseases, infectious disease, coronary vascular disease, or diabetes, and for the elder care, which is a very, very large portion of the population. So it's a much broader application. We've talked about it being borderless. And we also talk now about people in health instead of just patients in healthcare. This is going to be over a $500 billion industry by 2025, and this was pre-COVID estimates. It'll probably get over $650 billion by 2025, which is about 80% of all of biotech. So this is going to be a major, major component of how we take care of people in health. And we're not only enjoying the participation of our familiar faces in healthcare, but we're seeing unfamiliar faces from IT, social media, from retail health, and the new entries on the block are entertainment, from Netflix to Bose to Nike. They're beginning to get involved in the hub of people for their health. And one of the reasons that they can do that is that they have the ability to move people in a different way than what we've seen before. This is Disinterested Dave. Disinterested Dave wants to work out, but he'll get to it tomorrow. He's got one hand on the clicker, the other hand probably soon with a pizza, but he's got both eyes on the screen. And we've learned not just to wait till Dave comes with a complaint to our clinics or our hospitals, but the entertainment folks knows how to get into the fat part of the curve and get Dave interested in his health. Why? Because they use tools that we're not familiar with: guilt, reward, socialization, family pressure, advertisement. So utilizing other components in the consumer arena can participate uniquely in the component of providing healthcare. This is an example of one of the recent Stanford magazines with the stethoscope that is for one person to listen to one heart at a time. But we're seeing the democratization of diagnostic technologies, such as Echo, that can be brought to you outside the hospital with these small, portable ultrasound machines and transducers, and the display is just simply on your phone. This allows unexperienced physicians to get experienced information, whether it's your heart, whether it's the amount of urine left in your bladder, post-void residual, whether it's your liver, or whether it's your carotid. This allows not only guidance of optimization for those images, but diagnosis as well through machine learning and some AI. You're able to be guided in real time through cloud-based communication through the intercostal spaces to optimize that, say, 4-chamber image or that cross-section of the papillary muscles. Again, this is an important democratization so that people could triage more effectively in remote settings and not have to come to the large medical centers to get their heart exam. As we move throughout our lives, we are becoming uniquely characterized with our digital exhaust and our footprints. Whether it was the restaurant that you were at last night and you'd like to ask about how the service was, or whether we're using this to communicate with our physicians, our healthcare providers. We end up touching our phone 650 times a day. We interact with it 150 times, send an email, talk on the phone. In the United States, it's 8 billion times a day. That information that begins to combine with other sources of information, such as smart speakers that are in the car your living room, and your bedrooms. Over 80 million US adults own at least one smart speaker. And you begin to coalesce the digital footprint from the palm of your hand to the understanding of your lifestyle while at home or in your car. And you begin to combine those with medical images, wearables, personal health information. You have an aptitude of data that is far more than what we've had in our episodic care that we've been used to providing with respect to our medicine. So this is a big change and a necessary change. I get the opportunity to work in Israel, where they've had 25 years of digitized information for 7.5 million people. That would be genes, personal health information, x-rays, images. And that gives you a temporal now data accumulation so that you can learn from the journey, learn from specific patients' cancer over time and how they were treated, and apply that to the new patient you're seeing with the same genotype or phenotype of cancer in their lung. Let me show you a couple examples. We used to go to the strip malls to get our eyes examined and walk out with an expensive pair of glasses. Today, you can do this in the palm of your hand by running through about a 2-minute app that gives you your full prescription and delivers your glasses at your doorstep within 24 hours. Again, this is the democratization of things. This is Blockbuster converted to Netflix. And again, there's a powerful information play, data play, that helps this become a reality. Take, for example, Mary, who unfortunately has Parkinson's disease. She can now control on her Samsung phone the duty cycle of how that pacemaker is interacting with certain part of her brain to keep her from having those spastic movements or the shaking movements of her hand. Now that might be not necessary today because she's staying home, but tomorrow she's going to a recital and she doesn't want to have the program shaking in her hands. So she can actually control. And how she does that is not only data from her over time, but data from many, many other people that are just like Mary, and gives you boundary conditions so that you can adjust for your daily activity over time. We've seen implants that have threaded wires up to the ventral intermediate nucleus, a $45,000 price for this for patients with essential tremor or Parkinson's disease. Today, rather than putting that expensive device in, you can put 2 wristbands on that analyze the acceleration of your right hand, of your left hand, of me versus you, and then applies the sensor technology to optimize the neurostimulus, but right at your wrist, right at those peripheral nerves. You can do this for 60 to 90 minutes in the morning and get 6 to 9 hours of shakeless lifestyle. This is an important component, but it's based on the temporal feedback of not only you, but other people just like you. This is a very, again, technological process that really is called digital therapeutics, but you're going to see more and more and more of these digital therapeutics. Let's talk about Maggie. For all the cardiologists or all the healthcare professionals in the room, you've probably seen people like Maggie. She's got 150/95 as her blood pressure today. Her creatinine is 3.2, and she's already on 2 blood pressure medications. Her past medical history is significant for Crohn's disease and COPD. What do you do with Maggie? Now, if you're a 60-year-old doc, you've probably seen a lot of people like Maggie, so you will either add another drug or subtract one of them and try that over time. Now we can put a blood pressure remote cuff and see how that does over time. But what's important for that decision is to find and derive through neural networks 160,000 people that look just like Maggie to optimize different outcomes over time. Again, that temporal component of data. So if you're a 30-year-old and you don't have as much experience in treating people like Maggie, you're going to choose outcome 1, because over time, for Maggie, it optimizes her potential therapy. It may not work all the time. That's why we don't like to call this AI. We like to call it IA, intelligent augmentation of the healthcare community. But it's important to derive those unique information from those unique data sets for optimizing healthcare. Yesterday, we would basically look at Google or any other source for our healthcare. Today, we can talk to the healthcare providers. It's reimbursed. There's over 200 companies. The one that everybody has sort of heard about is probably Teladoc. MDs, RNs, and physician assistants utilize this to communicate to patients at home. Patients are demanding this, and it's FDA supported. By 2027, the number of virtual visits will be double those of clinic visits. You'll need clinic visits, but you're not going to need as much. Just like we've learned from a forcing function, we've rethought how we interact. Here we're having a lecture that's through Zoom. We've repurposed, we've rethought. When I get to talk to patients at home in their living room, I like to bring their family on the couch so that their sons, daughters, friends, cousins can see what's wrong with Paul's heart. Now, I've changed the images, of course, to protect Paul, but nonetheless, I can show the mitral valve in a parasternal long view. I can show what the coronaries look like. I can show what his rhythm is. And I can begin to involve, answer questions from the family, and even involve them in their care. Have his son being responsible for the lisinopril that his dad takes, and maybe some of the other friends, their aspirin, Plavix, and atenolol. But it engages people. Paul has not been hospitalized for the last 18 months. Prior to that, he was hospitalized 3 to 4 times per year. So this makes a difference. This brings caring and empathy through technology into the home, which is very important. What we used to do in the clinic was frustrating. We'd be typing on our computer, looking at our screen, rather than looking in the eyes of the patients. And now there's technology that listens and learns to that interaction between myself and the patient at their home and extracts the important information out of it and puts it directly into the EMR. Now, it's not always perfect, but I'd rather edit a few things after the call that takes 2 minutes than try to enter it all in real time while the patient's in front of me. So these technologies have spurred subsequent technologies, which again is optimizing the way we provide healthcare. Even the retail health folks are getting involved in more detailed health components, such as providing peritoneal dialysis, hemodialysis within these retail floor spaces. Why? They're getting rid of the snacks and the candy bars and making room for patients, because those same patients need the medications that they have in the back of the store, as well as maybe the diapers and other types of entities for their unfortunate renal failure. Again, many participants along the spectrum of care for patients. This is a hospital in the upper left-hand side. It's called the virtual hospital. It's in the United States, the mid part of the United States. There's no patients in there. There's just people that are monitoring patients at 11 regional hospitals, intubating, extubating, releasing patients from the ICU, admitting patients to the ICU, having them on standardized medication for their given medical problems, and learning from it constantly. The telehealth technology allows you to coalesce the data that you've learned from people like we've talked about Maggie, so that you provide standardized care to those 11 hospitals. That's where the machine learning really becomes helpful. And this extends not just from where they're hospitalized, but where then they go after, to their care facilities or to home. And that's an important component going forward. I'd like to end by just talking about haptics or catheter motion, fingertip hand-eye coordination, which, by the way, the 30-year-old doctors are much better at than the 60-year-old doctors. We've already seen technology being able to be delivered through the fingertips, either 9 feet or 900 miles away, whether you're clipping a mitral valve or whether you're putting a stent into an LED. The technology that we have today with respect to cloud computing and the time it takes, facilitated by GPU speeds by NVIDIA, provides minimal latency. So this gentleman on the right-hand side can actually accurately place a stent in that woman hundreds of miles away, which has been done with this system before. And many more systems are providing remote care. Now, one might say, well, we have a lot of cath labs, so this might not be applicable to certain geographies. That's true. But what about this problem? When you have a stroke, you now have to get to a comprehensive care facility. That could be hundreds of miles away. There's 825,000 strokes in the United States per year, 550 in Japan, 675,000 in Europe. 22% of the time they die. 56% of the time they become permanently disabled, which is a huge healthcare cost and a real tragedy for the patients and their families. So if you're in the middle part of California and you have to travel an hour and a half or 2 hours to the Stanfords or the UCSFs, to that comprehensive care facility to go into that middle cerebral artery and take out that blood clot, while you're driving or being helicoptered, you're losing 1.9 million neurons in a minute. 14 billion synapses are dying and a lot of miles of myelinated fibers are being compromised. So today, we have that same technology that you saw for the coronaries or for the mitral valve to now be able to remotely put a wire, follow that by a catheter that grabs the thrombus in your, say, middle cerebral artery. So bringing that technology remotely through the technology that's been in the e-consumer arena and matured over the years is a very provocative and a very important contribution of some of these diseases. So whether you're 9 feet away or 900 miles away, you may be able to provide these important life-saving and morbidity decreasing for those with stroke. So healthcare of the future, from training to rehab, is going to change drastically. Medical students are not going to cut up cadavers anymore. They're in three-dimensional holographic presentations that not only connect the anatomy, but the physiology as well. Rehabilitation, when they leave the hospital and go to these care facilities, technologies from smart beds all the way to telehealth at the home is going to help with that continuum. And comprehensive care facilities will be the new name of our big medical centers. And rather than waiting for the patients to come to us with their problems, there's going to be remote diagnosis, remote therapies from what you saw with respect to stroke, or even providing care at a different level for smoking cessation or drug addiction. But that care process is going to expand by utilizing some of these technologies. And of course, brought to you by the Amazons, the Apples, the Googles, the Facebooks. This is a picture on the lower right-hand corner of one of the hospitals in Texas. That's what the basement looks like. It looks like NASDAQ, but they're following patients when they leave the hospital to their intermediate care facilities or at home, providing standardized and more optimized care for that patient's journey. So in conclusion, there is a tectonic shift going on as we embrace or rethink how we're going to deliver care by combining some of the technologies, this coalescence of disciplines, because digital health is going to help us with that continuum of care, that value care, optimizing care and cost. True partnerships with IT, media, retail, and entertainment folks are combining into life science efforts. Products are being enhanced by data sets and analytics, We're intelligently augmenting the healthcare folks with these rich data sets. And this innovation and integration into healthcare, brought to you by Digitizing Medicine, is at an all-time high and has continued to be that way as we ultimately provide better care and hopefully shift the curve maybe in the right direction. Thank you very much for your attention.
Thank you so much, Professor Fitzgerald. Next up, we have a brief break or recess. We're going to be taking around 10 minutes or so. So you're welcome to stretch your legs, grab a snack. Please try and be back by a little bit before 6 p.m. Pacific or 10 a.m. Japan time. And we'll see you in a little bit. Enjoy the break.
Imagine an innovation center for the life sciences that combines state-of-the-art lab and office space with a virtual platform to facilitate collaboration and growth. Shonan Health Innovation Park launched in 2018 as the first mixed-model science park in Japan and has evolved into a dynamic hub for nearly 100 companies and 2,000 innovators, from startups to multinational businesses to academia and government, with the simple mission of fostering the partnerships and collaboration needed to move the life sciences forward. In 2020, the world seemed to stop, with physical distancing due to COVID-19. But iPark members have leveraged its virtual platform to expand their networks and get matched with partners to advance their research and grow their business worldwide. For life science companies looking to enter markets in Japan and Asia, iPark is a one-stop hub, offering access to research facilities and collaborators, startup funding and business support, as well as navigation through the regulatory process. Connect with us at iPark to chart a path forward for growth and innovation through the challenges of our new normal and beyond.
Born in Japan, MUFG is one of the world's leading financial groups. Our Japanese roots go back over 360 years. We established an overseas presence in 1880. Today, MUFG comprises 300 companies worldwide, offering commercial banking, trust banking, securities, credit cards, leasing, and many more fields of financial services to meet every client need. MUFG has a proven track record worldwide. Project finance is one example. MUFG has topped the Project Finance International League tables for years. MUFG's network spans more than 50 countries with over 180,000 employees worldwide. We continue to offer our services with a global reach, from the Americas, Europe, and the Middle East and Africa, to Asia and Oceania. To accelerate growth, we are pursuing new business partnerships and taking on new challenges, bringing us a string of successes in diverse areas. We constantly strive to strengthen our global network. Our investment in Morgan Stanley lets us leverage the global reach of this world-leading investment bank to amplify our influence in M&A and large-scale finance. In EMEA, MUFG has bought the project finance assets of the Royal Bank of Scotland. Our two banks in the Americas integrated operations. This synergy of a global financial institution and a steady earner of US dollars bolsters the group's competitive advantage. In Asia, our acquisition of Thailand's Bank of Ayutthaya, known locally as Krungsri, and Indonesia's Bank Danamon enable us to launch a full suite of high-value financial services in the ASEAN region. We are also working in cooperation with partner banks around the world.
Works behind the scenes, building the future today. Innovation that shapes the future. NITO.
At NITO, we have no barriers. Our technology connects the world's brightest minds, creating a network where nothing is impossible. No matter how many times we have to try, we're sure to find the right answer. Because at NITO, we believe society can change.
Innovation for customers. NITO.
NITO works behind the scenes, building the future today. Innovation that shapes the future. NITO.
At NITO, we have no barriers. Our technology connects the world's brightest minds, creating a network where nothing is impossible. No matter how many times we have to try, we're sure to find the right answer. Because at NITO, we believe society can change.
Innovation for customers. NITO.
Triple Ring is a co-development company. We stand side by side with innovators and entrepreneurs to solve hard problems, launch breakthrough products, and create new businesses. Triple Ring has been in business for 15 years. With offices in Silicon Valley and in Boston, we've performed over 500 projects. Our staff of over 100 scientists, engineers, and developers work on projects for startups and many of the world's largest companies. At Triple Ring Technologies, we turn science into commercial success. Whether in deep tech, MedTech, or biotech, the most innovative products integrate advanced science. These products can't be developed by recipe. They require a rigorous understanding of first principles. Triple Ring is an international leader in life science, medical device, and healthcare innovation, servicing broad market areas including in vitro technologies, medical devices, photonics and imaging, advanced technologies, drug delivery, and consumer health. Most companies value teamwork. At Triple Ring Technologies, we were founded on it. Please contact us to discover how we can collaborate with your organization.
Hello, welcome back everyone. It's time now for the second half of our conference. So we have a lot of really interesting topics to go over. So our first presenter for this half is Mr. Raphael Rakowsk. He is the co-founder and executive chairman at Medically Home Company.
Hi, my name is Raphael Rakowsk. I am the executive chairman and co-founder of Medically Home, tech services company and logistics business that provides all the tools necessary for health systems here in the United States and abroad to enable high acuity medical care at home on behalf of health systems that are looking to change care to a decentralized model. Our journey began about 12 years ago. I was joining the board of an academic medical center, and unfortunately my father was admitted there as a patient at the same time and tragically lost his life from 3 medical errors while I was watching. The heart of what I discovered when digging into the root cause of the issue was the high fixed costs of hospitals, typically 65 to 70%, leaves very little actual reimbursement for medical care delivery, roughly 35%, creating an enormous amount of pressure on hospitals to rush the patient out of the hospital, to transfer and hand the patient off frequently in a very industrialized model of care. And the thought was, what if we moved the patient home? And in that side of care, didn't have the pressure of moving the patient out quickly and could provide more care over a much longer period of time to reliably get better outcomes compared to the model that we've been using for the last 150 years. As this idea took hold, did a series of pieces of research and development, published a clinical trial, and moved patients out from the hospital to the home successfully in Boston with our first high acuity patient. And then that got picked up by a number of other health systems. And we moved from high acuity care for traditional hospitalization substitution to cancer care, COVID care, and formed a partnership with the Mayo Clinic. And about a year ago, a little bit less, CMS, Medicare in the United States, enabled the payment for this model through a series of waivers that we were part of getting put into place. And as the model has evolved from multiple use cases and different clinical applications, so has the ability to reach patients in rural areas in the United States. The heart of the idea is moving care, which has been centralized for, as I said, over a century, to a decentralized model, moving the model of care delivery, which is currently organized around payment and around facilities, to have it organized around patients and their homes. The challenge of that is the decentralization of care requires a whole different series of capabilities, most importantly logistics and software, to enable the way in which we actually deliver care to patients who are remote to the care delivery site. The market itself over the last year has gotten very frothy, mostly because of COVID and patients' fear of hospitals and the demonstration that the hospital systems, both in the United States and abroad, did not have the flexibility necessary to be able to care for patients as volume went up and down in these various markets. And as a result, there's been a very thoughtful exploration of whether or not the centralized care delivery model needs to be revisited, and that's what's driving a shift of care to the home. The essential elements of our model can be really summarized by the idea that we acutely care for patients in a home setting. And in the United States, the spectrum of acuity typically ranges in a metric that goes from 1 to 4, 4 being an ICU level patient, high acuity, 1 being the lowest level of acuity that a patient can justify being in an actual hospital setting. Our focus has been on the 3s and the 2s. These are patients that require longer lengths of stay, frequently require services, diagnosis sometimes changes, and the response time necessary for patients is rapid. In order to do that, we've organized a model where there's a central command and control with physicians, nurses, nurse practitioners, care coordinators, logistics professionals, supported by a field force of 18 services that go to the patient's home rapidly on demand, connected to this command center, and supported by technology in the home that allows us to communicate and monitor patients reliably and quickly. Lastly, a software platform that allows this model to operate with full integrity and fidelity as a standalone hospital while fully integrated with the electronic medical record of the host system. We admit patients from multiple sites, from the hospital's emergency department, from the ICU, from urgent care centers, from the primary care clinic, and even patients who are homebound, we can actually admit them from their home to their home, and all the activities on the front end of an admission, including triaging, labs, testing, is performed for the patient at home. The heart of the model is this command center that I referenced. It's staffed by emergency physicians, hospitalists, intensivists, and now in the work that we're doing in the field, we're also staffing specialists to support specialty care in the community. The difference between our model and telemedicine is while this is a telemedical encounter between the patient, family, and the command center, the effector arm or the services in the community that this medical command center guides and organizes allows the clinicians in the command center to actually deliver care rather than just a consult. This acute supply chain that I referred to provides 18 different services to the patients rapidly at bedside, from paramedicine, nursing care, medications, infusion, phlebotomy, labs, imaging, across the board, including the ability to ensure that we have integrity of information going in and out of the home rapidly. All of these services are integrated into a single platform and managed by Medically Home. The entire idea of Medically Home was actually inspired by military medicine logistics. So think of a soldier in the field that's injured. You have medics, which are a lower licensed clinical professional in the field with the soldier, connected to a medical command center staffed by physicians. In essence, the physicians are virtually in the field. The difference between that, as I said earlier, and telemedicine is these physicians are actually having arms, legs, and ears and equipment in the field that they can guide the delivery of care. This model has been around for decades, and now we've applied it for decentralized care for patients at home. Our partnership with Cardinal Health has allowed us to scale this model, and this model of decentralized care supported by logistical support is, again, the heart of the idea of tethered medicine. In the patient's room or home, we provide all of the tools necessary for the patient and the family to access the status of their care, access their team, and importantly, the patient and their family can access the physician and attending clinicians 24 hours a day, 7 days a week. Unlike a hospital, a patient and a family member would like to see or talk to the doctor. That's often very, very challenging. This platform provides monitoring, education, documentation, outcomes reporting, and vital signs monitoring and capabilities. The software that supports this virtual hospital has full integrity, is delivered in an integrated fashion, providing all the monitoring capabilities, care coordination, supply chain coordination, and importantly, fully interoperates with the host electronic medical record, allowing attending physicians who are caring for patients to document in their host system, to actually write orders in their home system, and our system and this home system integrate so the patient and the family and the physician can operate on a single platform. This is an important element of our capability, which is understanding the difference between lower acuity and higher acuity patients. There are roughly 100 programs operating in the United States for hospital at home on the low medium acuity scale, and on the highest scale, which is in red on the right, the ICU level patients. That patient requires being in a facility given the unique clinical and response times necessary to care for that patient safely. The high medium acuity, which is on the right side of the spectrum below the ICU, is where our focus is, and primarily because lower acuity patients represent a much smaller volume in a hospital, typically 5 to 8%, where higher acuity patients represent 20 to 30%. The higher acuity patients have significant comorbidities, longer length of stay, higher readmissions. The patients tend to be older, and they require rapid response. Because of this rapid response nature, the systems to support them are completely different in requirement than lower acuity. As an example, you could safely care for a lower acuity patient by having physician house calls and scheduled nursing visits to the home. You could do that safely for a very short length of stay, say 3 to 5 days. A higher acuity patient may require rapid response upwards to 10 times a day, require a much longer length of stay, and a much more complex model. So as we look at the difference in acuity, this is a patient sample. The orange on the right are patients that are high acuity, and on the left in blue are lower acuity. And you could just see the number of times we touch the patient, the length of stay, both in the acute and the post-acute phase, but most importantly on the right, as you can see, the costs of caring for these patients at the lower acuity level is less than half of the higher acuity. So the economics, the intensity, the speed of higher acuity patients are remarkably different than lower acuity patients. Another key element of our model is the ability from this platform to deliver high acuity care to extend and expand into multiple different use cases. We're currently using the platform to do high acuity emergency department care at home, specialty care at home, and very, very soon we'll be doing other applications of the model following the launch last year of oncology care at home. The basic idea is if you can substitute for the high acuity patient population in a hospital, there are multiple use cases you can go across the spectrum, including transfusions, ventilated patients, pediatric patients, etc. The ED, the Emergency Department and Home program that we started in Boston about 9 months ago, has about 1,200 patients now. And what we've learned is that the average level of acuity that patients in our model at home have is roughly 8 points higher than the actual emergency department in Boston that we substitute for. The reason is we triage earlier before we actually dispatch, and the triaging process allows us to ensure that services both from the clinicians going to the home as well as the equipment that we deploy is effectively being used based on the acuity level of the patients. This idea of high intensity emergency care at home allows us to proactively reduce the burden on emergency departments, meet the fears and concerns that patients have of going to the ED during these COVID times, and reliably reduce admissions to the hospital. This is another program that we're launching in rural parts of the United States. It allows us to use the same platform of this command center located centrally, acute response services to the home, particularly in the most remote areas of the state, and the technology that integrates this. This allows us to safely and reliably reach patients, provide access to care in the most rural parts of the country, and we intend to take this model around the world for rural populations globally. Last slide. I know I've gone very quickly. Hopefully we'll get a chance to do Q&A later today. The wealth of information that we now have about this type of model with others doing forms of it and us is that we have about 25 years now of evidence, including significant numbers of randomized controlled trials, that demonstrates the home is a safer site of care to recover from acute illness across the board, from mortality, morbidity, falls, infection rates, level of sleep, cognitive decline. All key measures demonstrate that the home is a safer site for recovery of acute illness rather than a facility like a hospital. Over 100 hospitals, as I mentioned, are currently using the hospital-at-home model that's been blessed by CMS for reimbursement through this waiver. And everything that we've learned from COVID has taught us that the current bricks and mortar based system is just not flexible enough to respond to growing demands and needs from the health system. So thank you very, very much for taking a quick perusal of this slideshow, and I will see you all in a little bit.
Thank you, Mr. Rakowski. Our next speaker is Amar Kendale, the Chief Product Officer at Teladoc Health.
Hello, my name is Amar Kendale, and I'm the Chief Product Officer of Teladoc Health. And I'm delighted to be here with you today to talk about the digital transformation of healthcare, how healthcare is being rapidly changed through innovation and changes in consumer and physician behavior. So a little bit about Teladoc Health. In 2002, we set out to find a better way to connect doctors with patients, and we knew that this could be possible with the help of technology. Today, we're recognized as the global leader in whole person virtual care, and we're serving this growing need from consumers and healthcare professionals to make use of technology to deliver care at broader scale. So what Teladoc Health does is it delivers, enables, and empowers virtual care services across every stage of a person's health journey, from wellness to prevention to acute care to even complex healthcare needs. So our vision is really to deliver a very broad spectrum of care services. But for the consumer, that has to be an integrated experience. So when we talk about a whole person care journey, our goal is to really bring all of these resources together, wrap them around the individual, with the help of technology, match that person up with exactly the right resource and capability at the right time. Because of technology and the global scale that we have, it means that we can deliver millions of these virtual care visits every year. And they're delivered on a consumer's own terms, on the channel that they want to receive them, at the time that they want to receive them, from exactly the right level of healthcare delivery. We're doing this now across a variety of different healthcare domains that include primary care. It includes mental health care, a growing need, of course, globally, especially one that's been accelerated by the global pandemic of COVID-19. Urgent care, which is really about rapid response to immediate needs that need addressing. Specialty care, consultation, for example, with a specialist for a second opinion. Chronic care, which is this long thread of living with a chronic condition, typically more than one, that requires a different perspective to care delivery. And complex conditions. So this is situations where we might be talking about surgery planning or other complex regimens. So in all of these areas, virtual care has begun to play a really important role when it comes to access, affordability, and quality. And Teladoc Health has brought these pieces together in a model that we think is really going to be unique to drive the success of the individual who sits at the middle. I'm going to go a bit deeper into a particular aspect of how we're building virtual care, and that's in regard to the combination of primary care and chronic condition care, and really recognizing that these relationships are longitudinal and require a different mindset when it comes to primary care delivery. The reason for this is that healthcare is complex when it comes to people who are living with chronic conditions. And I'll just highlight a few of the problem areas that we've identified as critical ones for us to solve. So one is that it's often difficult for a person to find the healthcare that they need at exactly the right time. And that could be ongoing support, coaching. It could be everyday care, getting access to resources or a medical consultation, or even something more acute, an emergent phenomenon that needs review. So that idea of access and availability can be challenging. Next, what we find is in many cases for people with chronic conditions, the care is delivered too late. Rather than immediate response to a scenario that's emerging in a person's daily life, it might be weeks, months later before a person actually sees a provider and is able to address that issue. So this proactive opportunity is still out there, while most of care today is delivered in a reactive fashion. Next, we have the fact that people are different. Everyone's health needs are different and their environment's different. And so the timeline for a given consumer or person living with a chronic condition can be very different from another person with the same condition. So that personalization, the variability needs to be accounted for in that healthcare journey. And then finally, I'll comment here about the fact that with large, complex needs come large and complex care teams. And historically, this has been another big area of challenge. That coordination between different parts of the healthcare system has not been easy, and therefore there have been gaps in care that have emerged. So the other place that all these complexities show up in driving a significant problem statement is when it comes to cost. So at the heart of it is when you consider complexity, when you consider longitudinal conditions, and you consider the fact that for most people living with a chronic condition, there's very typically another chronic condition. In fact, the majority of people with chronic conditions are living with more than one. And so this translates directly into high cost, but not only high cost, exponentially high cost. So as you add more chronic conditions, the cost of care really skyrockets. And a person who's living with, for example here, diabetes, high blood pressure, and a comorbid mental health need can have healthcare costs that are easily 5 or more times what it might cost to manage any one of those conditions alone. So a grave problem when it comes to managing cost in these complex. So where's the opportunity? As we see it, the opportunity is to really integrate what we call whole person virtual care services. So take stock of everything that's going on in that person's life from a health perspective, provide personal health support, be there in the moment, establish a longitudinal relationship, not with just a single provider, but with an entire care team. And then when needed, deliver that episodic care, on demand, rapidly responding to an emergent need. And we've been able to build this on a foundation that we've built over the years, starting with clinical quality, using evidence-based medicine as the foundation, adding to that a consumer-oriented health experience, something that feels great, that feels as good as the experience you may have as a consumer of any other products in your life outside of healthcare, and doing this at a scale that's really unmatched globally, and making sure that we have the capacity and the coverage to really address the needs that people have. So our services ultimately have been designed to support behavior change, because that's really so much of what we encounter to be where the action is, where the needs are the greatest, and where the opportunities are the greatest for our members. That's what we call our users. So in this idea of designing for behavior change, we really took a pretty different approach to the solution for these healthcare challenges. Rather than focusing on the physician or focusing on the care provider, if we begin to put our focus on the member and their daily life and the actions that they take as part of their daily life, we find that there's an opportunity to create enormous leverage in the kinds of changes that a person can take on for themselves. So one piece of this is starting to instrument that individual and making sure that data collection is effortless. So in order to drive any kind of behavior change, what we've learned is that we need to have very good quality data that's available to us in as real-time a fashion as possible. So high throughput, as low latency as we can possibly create, and with very high clinical quality and accuracy. So that's step one. Step two is once we have that data flowing into our systems, we're able to apply algorithms in order to make sense of those data, to look for trends and patterns, and on the basis of those trends and patterns, deliver something very personal. That personalized health signal is the one that we found to really drive a change in action. And what that means is if we can identify the differences in how you might respond to a given action or call to action. Perhaps we're recommending exercise for one person and recommending a nutrition change for another. Using data in order to personalize that offer, to track whether we've been successful in what we've offered, has a person actually taken us up on the advice we shared, and then continuously driving that feedback to get better at these recommendations we make is a key component of how behavior change at scale works. And then the last thing I'll note here is that humans are in the loop. And this is a really critical piece as well, because it's just as easy to imagine going too far in the direction of technology, and taking people out of the picture means that we're relying exclusively on the technology to do jobs that sometimes simply can't be done by technology, no matter how advanced. And so this idea of the human touch, the human in the loop, is another really critical piece of what we've learned to be important. And so in many cases, these personalized health signals may trigger a reach out from a coach or from a nurse or from a physician, knowing that that is the best way to drive the clinical outcome that's going to matter in this circumstance. So when we have these different pieces and we put them together, the model we can finally support is something that really steps through care and begins with a broad digital layer. Think about this as the foundation, the connective tissue, a way for a person to interact on a routine basis as part of their daily life in a way that's consumer friendly. That's the digital component of what we deliver. But on top of that, we can very easily navigate an individual to exactly the right level of care. So on the basis of evidence, on the basis of personalization, we can decide whether maybe the right next step is actually for you to see your primary care doctor, or maybe it's to actually see a specialist. And once that's done, we can bring you right back down to that digital layer that's sustainable for you as part of your daily life and something that you can keep going with in everything that you do without having to incur that excess work on behalf of the member or excess cost on behalf of the payer. So I'd like to walk you through a journey, because I think all of these theories, while interesting, need to be brought to life. And so I'll take you through the journey of a woman named Claire. And Claire learns about Teladoc through one of our engagement programs. She'll receive an email message, perhaps, or a direct mail coming from her employer or her health plan. And she learns about Teladoc and decides to register. So the next step is to bring Claire in to really get to understand her at baseline. So we connect Claire to a Teladoc physician, and what we find is that she's living with high blood pressure and that this is an opportunity for closer management. So we enroll Claire in the Livongo hypertension program, and what Livongo makes possible is the delivery of a connected monitoring system. So that aggregation of data is going to come now from a cellular connected blood pressure monitor that gets shipped directly to her home. She's able to get started, and now that data starts coming into our system. So the care team can see this data coming in. They can monitor for trends and patterns and keep track of whether things are moving along on a good pattern or whether there's something that requires some work. So the data starts coming in, and Claire starts getting some very helpful and personalized health nudges. This is that personalized behavior change, those actionable messages that we deliver in order for Claire to know what to do. So those health nudges are giving Claire advice to stay on track, and whether it's the daily actions, a low salt diet, enough activity and exercise, managing her stress, those are all the things that she's recommended to do. Now, based on the data that we see, a worsening of Claire's blood pressures the Teladoc physician is able to immediately act and write a prescription for a blood pressure medication. Now, in the traditional model, it could be months before Claire actually has her data reviewed. She goes in for her annual visit, or perhaps it's another routine visit, but it could be months. Instead, now we're taking a proactive approach. We're looking at that data in real time. As soon as a trend emerges that's worrisome, our physicians are able to act. So Claire starts on this new medication. She also consults with a Teladoc nutritionist, and this is because we know that balancing medication and lifestyle is the way to get the best outcomes at the lowest cost. So Claire takes on some of these recommendations. She participates in a healthier diet, and she's off to the races. Her blood pressure management protocol and routine is starting to become a part of her lifestyle. Now, life happens, of course, right? And Claire is diagnosed with something unrelated to her hypertension. It's a sinus infection. Now, the really great thing about a holistic, whole-person approach to Claire's lifestyle here is that the Teladoc physician knows about Claire's other circumstances, and he's able to write a prescription for that sinus infection that also considers risks related to the other medications that she's on or other conditions that she has. And in this case, that physician is able to give advice about the risks associated with the over-the-counter medication that are related to her hypertension. I mentioned lifestyle being a really key parameter here in the outcomes that Claire can expect. And so we're managing stress with the help of a mental health therapist. We're working with a care team to continue to keep Claire on target. She achieves her target weight through the nutrition changes that she's made. Her blood pressure's on track. She's able to continue with those healthy habits, stay on the medication she's been prescribed. So all of this means lower medical and healthcare costs. You know, we're really driving care to the lowest possible level of cost in order to deliver the best possible outcomes. Claire has the life that she wants. She's not going in and out of the doctor's office or in and out of the hospital. She's able to make these changes on her own terms and on her own time. So the results, I believe, do speak for themselves. We're very proud of the member impact that we have with very strong net promoter scores that are over 60, very high member satisfaction, and we're resolving the concerns that people have very quickly. So we know that the service is working when we're able to really take care of what people are trying to get solved. The clinical impact is also showing in a reduction in hospital admissions. We're able to see a reduction in parameters like A1C when it comes to diabetes. We're able to identify hypertension as a condition for people who may not have been diagnosed. And ultimately, this is resulting in cost savings. Fundamentally, in order for our healthcare system to work, it needs to be cost effective, and we're able to document those savings that are coming from the improved clinical outcomes. So thank you so much for your time today. I really appreciate the opportunity to share the Teladoc Health story, how we've taken a whole person approach to these problems associated with virtual care needs, and eager to see you later in this evening's social sessions. Thank you again.
Thank you, Mr. Kendale. Our final, but certainly not least, presenter is Mr. Zaif Siddiqi, the Global Head of 5G and IoT Enterprise Business at NTT Docomo.
Firstly, I would like to thank Mr. Takahide Akiyama, President of the Japan Society of Northern California, the moderator, Dr. Fumiaki Ikeno, the number of collaborators of this event, sponsors, institutions, organizations that have made this event successful. Thank you very much for giving NTT Docomo the opportunity to speak at this wonderful event. My topic today will be on reaping the benefits of 5G in healthcare. For those who may not know about NTT Docomo, we are part of the NTT Group, NTT Group does roughly about 100 billion US dollar of operating revenues annually, and Docomo is the mobile arm of the NTT Group. We do an operating revenue of 43 billion US dollars, operating profit of $8 billion, and have a subscriber base of 80 million subscriptions, considering that Japan has a population of about 120 million. We do have the #1 share of mobile subscribers in Japan. So you could think of us like the AT&T of America. A quick introduction of myself. My name is Zaif Siddiqi. I am with the 5G IoT Business Department and leading the global business strategy and promotion for the various services that we provide. I also serve as a board member of the Docomo overseas branches, and here are some of the solutions that I would like to show to you, which we are providing in the 5G era. Unfortunately, I would not have the time to go through each services, but you can see the number of services that are already out here, and we already have over 30 solutions that utilize 5G, AI, multi-edge access computing technologies and infrastructure to provide various services and solutions into different industries. These technologies can also be used in the healthcare, and I would like to highlight in the latter part of my presentation on how these technologies are used in the healthcare. So how does Docomo define digital transformation in the 5G era? There are various technologies such as IoT, AI, XR, cloud, and Docomo keeps 5G and multi-access edge computing at the core of these technologies to create digital transformation. With the various data that is collated through these technologies, we bring the physical and the cyberspaces closer together so that we could create more meaningful data that can allow us to make better decisions using these technologies and come up with radical improvement of user interface and user experience, come up with creation of innovative services, improve the productivity, and solve the various social issues and create new value for the various solutions that we come up with in line with the government policies and the market behavior of that particular region. "5G and MEC strategy execution will be extremely critical in these various areas. I would not have the time to go, of course, into all these areas, but as our topic of today is smart hospitals, and if you actually collate all these things together, before I run into the smart hospitals, it actually does create a smart city. Of course, we can add more industries and sections to this, but smart city is a collation of various industries put together. So let's get into smart hospitals. So from here onwards, I would like to share with you how Docomo is contributing in the area of remote patient monitoring and how we use the technologies that I mentioned earlier in this space. So here you see resolving societal issues with 5G. How can we resolve in the medical area? What are the issues that arise in the medical area? There are many, but I think we can highlight superaging society, lack of medical personnel, COVID-19 pandemic. There are many other issues, of course, but these issues are some of the issues that Docomo took as a challenge to see how our technology and how our partners' assets, Docomo's assets, in this digital transformation area can lead to the resolution. So we have prepared 3 areas: connection of central hospitals with remote clinics, advanced medical care, utilization of AI, and sanitization robots. So these 3 areas will be highlighted by use of videos and introduce you how Docomo is working in the medical area. So there are many people who do not get medical attention, especially when they're located in a very small clinic like this right near the beach, and there are very few people, maybe they're located on an island, and they may require a certain degree of higher standards of medical attention, but unable to because of the facility that they have in their area. So Docomo conducted an experiment with Wakayama Prefecture and the Wakayama Medical University to see how a general hospital can support through the medical consultation room using high-speed capacity of 5G and utilizing high resolution and real-time 4K transmission to deliver CTs, echoes, and conferences, having direct conference calls while diagnosing the patient who's located at a remote clinic. To demonstrate this, we have a video which I would like to show you, and hopefully that will give you a better idea of what kind of experiment we did.
人口減少や過疎化の進行により、地方と都市部との医療格差の拡大が課題となっています。この課題の解消にも寄与すべく、和歌山県立医科大学と NTT ドコモは共同で、第5世代移動通信方式 5G を用いた高精細診断映像による遠隔診療を行うシーンをデモンストレーションしました。
従来からある 4G の画像と比べて 5G の画像はより鮮明に皮膚の状態を見ることができます。またエコー画像もですね 4G と比べて鮮明にクリアに映ることができるので遠隔外来や遠隔診療に関して非常に有用に役立つと思います。
5G の高速大容量通信を生かして複数の高精細な診断映像とテレビ会議映像をリアルタイムに同時伝送するシステムの実現により、どこにいても高度な医療を受けることが可能となります。
So I hope that gives you an idea of how 5G can give a much higher definition and clear image of the patient's wounds or injuries, so that the people in the consultation room can assist the doctor in the remote clinic and also deliver data that he or she may not have access to with the various facilities that are only available in the general or the bigger hospitals. Next, I would like to introduce you SCOT, which is the Smart Cyber Operating Theater. This was an experiment, and it's an initiative that we are working with the Tokyo Women's Medical University and other collaborating partners to develop a mobile treatment room. And as you can see, this big truck is actually equipped with a mobile treatment room and has a great facility whereby using a mobile strategy desk, a person who can be remotely located can support the surgery that goes on in this big mobile treatment room. So this one utilizes the feature of high capacity, high speed, and low latency, which are the two features of 5G. What this provides is real-time 4K transmission, and the good news is because it's location free, this truck can be running anywhere as long as it has access to the 5G network. So here's also another video that I would like to share with you so that you get a better understanding of how this operates.
スコットは東京女子医科大学が主導して開発した高い治療精度と安全性を持つスマート治療室で、治療室内のさまざまな医療機器をパッケージ化およびネットワーク化した上で、自国同期した検査・診断データを情報化することで、治療の進行や患者の状態を総合的に把握可能にしています。情報化の対象は MRI や 4K、8K カメラなどの検査機器からの高精細映像、患者の生体情報など多岐にわたりますが、これらを統合表示する戦略デスクの導入により、治療の進行状態を俯瞰的に把握しながら 戦略的な治療を行えるようにしています。さらに戦略デスクを治療室内にも設置し、経験豊富な熟練医師が治療室内と同じ情報をリアルタイムに参照しながら、治療にあたる医師やスタッフへアドバイスすることも可能です。このスマート治療室と戦略デスクの一方または双方に、超高速低遅延で通信可能な 5G を活用し、スマート治療を遠隔支援するモバイルスコットとしてシステム化することで、スコットの運用可能な場所と時間を拡大することが可能となります。対振動性を強化したスマート治療室をトラックに積み込み、5G を介してネットワーク接続したモバイル治療室の実現により、例えば専門医師が不足している地域や大規模災害の発生地域などにおいても、緊急対応を要する患者に対し高い精度の診断を行い、その結果に基づく早期の治療ができるようになります。
So this was the introduction of this smart cyber operating theater. It could be used in the event in the situations where we have earthquakes or natural disasters, and some of the hospitals in that area may not be able to function the way they should be. So those people who require emergency treatment can be treated in this mobile theater and connected to the mobile strategy desk over here, and gain immediate medical attention, or at least get some of the immediate medical attention that they require, so that their lives can be saved at an earlier stage. Other than these remote monitoring services that we provide over 5G, we are also working with the current COVID situation and the pandemic that is going on with Smart Robotics is a company that Docomo has partnered with to come up with infectious disease countermeasure. So this robot is equipped with a germicidal lamp, and this can be placed in hospital and general facilities of various buildings, in malls, in offices, at stations, and it can be controlled remotely using a PC or a smartphone over a 5G network. So this lamp basically kills the germs that are in the area or the space, and it actually helps in ensuring that we don't spread the infectious disease and mitigate those issues and problems that arise from the infectious disease. The services provided are the operation support, the device connectivity control, and of course all the data and the log are collected from what the robot is collating over the 5G network, so that there could be alerts sent to the smartphone or the PCs. Another example of infectious disease countermeasure would be density and detection. So in terms of density, we are referring to the physical distance and understanding, making sure that people maintain that physical distance. And this is a work that we have worked with Edge Metrics and Vakai. And what we're doing is we provide a total support from the AI application that is provisioned to device selection and installation. So what we do is the AI applications are uploaded by the various developers to this Edge Matrix store, and those users can actually have this Edge device with with cameras, for example, and connect through a 5G network and also with the LTE network, and use these applications as a service. So these can detect whether people are maintaining physical distance, or also do a temperature checks remotely and ensure that those people, for example, this lady is at 37.7 degrees Celsius, which is above the average, and could be detected. And there could be other ways of using this, checking on trespassing, doing human counts, car plate number recognition, checking if there are flames or smoke. Also ensuring safe sleep, especially for toddlers and babies who may be facing down, or even for those who may be old people who face down and may have issues with breathing. So we can get an alert to immediately give them the attention that they need. And finally, I would like to share around XR and how it can be used in the medical area. So here's another video that I would like to share, and hopefully this will give you an idea of how these head-mounted glasses can help. And this is a software which uses the HoloEyes MD, and this can provide you with some information on how XR can support the medical industry. So this is only showing the video only and does not come with narration. But as you can see here, the green part is actually the tumor section, and the people in the operating theater are able to understand the patient's situation with this HoloEyes MD, and able to understand what is the area that needs to be cut out, and ensure that they work on a safe surgery and are well informed in advance of the area that they need to work on. So this can be shared as long as they're wearing the headset and have that conversation while they're doing the surgery to make sure that they're doing the right surgery at the right spot. Thank you very much for your time, and I look forward to meeting you all at the networking session.
Thank you so much, Mr. Siddiqi. Next, we're going to be transitioning to our Q&A session, which is going to be moderated by Dr. Ikeno, whose presentation you all saw earlier. We'll also have some of the speakers present. If you've got a question that you want to ask them, please make sure you write it in chat. And if there's a specific speaker you want to answer it, please also indicate that in chat. So without further ado, I'm going to turn it over to Dr. Ikeno for the Q&A session.
Okay, thank you. Ladies and gentlemen, thank you for sitting in front of your computer for so long. This is because digital technology and the pandemic are happening at the same time. The pandemic is still ongoing, but as I mentioned in my keynote speech, this is when the digital transformation for healthcare has made a paradigm shift from nice to have to must have. In this sense, I would like to encourage everyone to think about the digital transformation of healthcare with the awareness of post-corona. So we have about 15 minutes for Q&A session to each speaker. I have prepared a few questions. Of course, I will take audience question too. But I'm sure the audience will have many questions, but there will be a breakout session afterward with each speaker. So please feel free to ask the speaker directly at the breakout session. I think this is a very rare opportunity to speak the keynote speaker directly. So, but at first, I'd like to ask the same question to Amar and Raphael. So at first, maybe Amar, who pays for you? Who pays for you? This is first question.
So our services are paid for by the health insurer, the entity that's really responsible for the cost of care. In some cases, for many people, that's an employer who is responsible for bearing the cost of a person's healthcare. In other cases, it's a health plan, a health insurance plan that bears the cost. And in some cases, it's the government directly that's paying through Medicare or Medicaid. So it varies across those constituents, but we found that the payer is really the most motivated to pay, particularly where the objective is to save money over the total cost of care, as opposed to for the individual episode of care.
Okay, thank you very much. So I will ask a different question. Who is the decision maker to join your service, like a patient, health insurance, or employer, or family doctor, or hospital?
So there's two decision makers. The first is that the payer needs to decide to work with us to cover the service, and that's what we think about as the first sale. The second is that we have to then sign a new member up, convince a consumer that they should try our service out. And we're typically able to directly offer this service as a covered benefit to those individuals who are eligible. So if you're a person who works for an employer that covers Teladoc, and you're offered the service, perhaps it's through an email that you're receiving from your employer, perhaps you see a promotion, you can sign up, and at no cost to you, you'll benefit from the service.
Okay, oh, that's good. So the last question, the doctors and the nurses belong to your service company, your company like a Teladoc, and if so, is that the exclusive contract, or they can work for another entity?
That's a great question. So we have our own network of physicians and nurses and coaches, and it's a mix is the answer. And I think much like you might encounter transformation in other segments of the economy where you have the emergence of a gig economy, but yet you have a lot of full-time workers as well. We found that we are operating in that same continuum, and in some cases, particularly in some specialties or some aspects of clinical practice, bringing those individuals in as full-time employees makes sense, and we have them on staff. In other cases, particularly with regard to the flexibility that many physicians are seeking, they prefer to be part of our service as consultants or part-time workers because they're looking to have flexibility in their lives, or they're looking to augment their income. So it's a mix, and I think that's going to continue for some time. Okay,
thank you very much. So I will move to the question to the Raphael, exactly same question. So medical home, more focusing to the acute care, the service companies. So Raphael, same question, who pays for you?
The services that we provide are to enable health systems, hospitals to actually deliver the model. So the payment is actually made to the health system for the episode of care. And we are paid then concurrently by the health system by setting up, in effect, a contract to create virtual beds for them. And we charge for those virtual beds per month. Very similar if they were building a new medical tower. The leasing cost of that tower per bed is the business model. So the payer, same as with Amar, the payment is for traditional Medicare fee-for-service, Medicare Advantage, Medicaid Advantage, commercial insurance employers, exactly as in the Teladoc model, except that payment is made to our customer, and in turn, our customer licensed with us the virtual bed contract.
Okay, thank you. And who is the decision maker to use your service, like a patient, health insurance, employer, family doctor, or hospital?
I was smiling when Amar was giving his answer. He has two sales. We have about 90. So we begin with the health system, not the payer, because we're totally changing the delivery of a model that's been the same for 150 years. High acuity patient care at home requires confidence for the clinicians. That's the first decision. The second decision is the CFO at the health system that's going to have to change the way they bill and conduct the way they actually manage their revenue cycle, because it's a completely different model. The third decision maker is the payer, but we have very strong payer relationships because our partners include Mayo Clinic and other high-profile customers. So they already have very strong established relationships with payers, so we don't have to create new ones. The fourth decision maker, the most important, is the family and the patient. When they have high acuity needs, the thought or prospect of being cared for at home requires a very large leap of faith that they can actually be safe in a home environment with their level of acuity. The fifth and the final sale is really to get the entire community behind the model, because we're hiring and training a whole cadre of community-based resources and decentralizing the care, which means things like nursing goes to the home. Paramedics now have to be upskilled and uptrained for a completely different model. We are changing the way in which community or care provision is done from a post-acute level today to a high acute level. So about 5 major sales, and I'm envious that you have 2 and 1.
Yeah, great. Yeah, great. the last question, the doctors and the nurses, or sometimes paramedics, belong to your company, like medical home? No,
we have,
okay.
no, our model is exclusively to enable our customers to deliver the care with their own clinicians.
Okay.
However, in Boston, we have an R&D center with about 35 people, and we do all of our next gen. So we did cancer there as an example. We started incubating that 2 years ago, and now we're doing transfusions and pretty soon NICU at home. So all of the kind of the next gen we do with our own clinicians, but only in R&D mode, and then we transfer all that know-how to our customers.
Okay, thank you very much. Okay, let's move to the question to the Zaif entity Docomo from Japan. So everybody knows Docomo. I have two cell phones. One is AT&T and the other one is, of course, Docomo. So anyway, I was surprised by Docomo's advanced project for telemedicine. So 5G is the key of digital transformation of healthcare in both US and Japan. So according to the meeting between President Biden and the Prime Minister Suga last week, they concluded the collaboration of innovation is crucial and 5G is one of the focus areas. Of course, healthcare is another focus area. Now, how far has the 5G service progressed in Japan? Also, what's the penetration rate in remote area and isolated island where telemedicine is the most needed? Since only a few people live in this area, I think it will inevitably take a backseat. So that's question, Zaif.
No, Ms. Dr. Ikeno, thank you very much for a great question. Definitely Japan, US, I think one of the top countries, we are, I think, leading in the 5G space. We've got other countries upcoming as well. But in terms of the penetration into the market, Docomo is going at an unmatched deployment speed in getting 5G nationwide. By 2023, we target to have a 55% population coverage throughout Japan, and hopefully we'll reach to about above 70% level in the following year in 2024. But going forward, the cost of deploying, as you mentioned, in remote areas where there are few people, of deploying 5G network is very expensive. But I think as new devices come along, and as we come up with better technologies and with also the software being a very strong engine as part of the network, and technologies becoming coming at lower cost, I think as we move along, there's a great potential that this can be accelerated with the help of the ecosystem partners, especially those who are providing the radio antennas. So I think these equipment makers, and as we move along with the infrastructure and with given the pandemic situation, it has also forced the various industries to actually get this remote working and things done remotely faster. So I think that has been a push as well. While we want, of course, the corona pandemic to be mitigated and seized, but I think that has also pushed us to work and come up with better ideas on how we work together.
Okay, thank you very much. Thank you for NTT Docomo. So
thank you very much. And thank you for using our phone as well.
Yes. So next question to Amar again. Amar, so Teladoc is a well-established telemedicine provider in the United States and has already been around for nearly 20 years. During that time, digital technology has evolved remarkably, and I believe the level of telemedicine has improved dramatically. In particular, I think the management of chronic disease using digital service devices, which Libongo provided, is an example. However, I believe it is essential for doctors to examine the patient in subjective things, such as palpation and auscultation and the patient psychological condition are possibly only available with face-to-face care. Do you have any plan to do these things about telemedicine? Because this is because the president of the Japan Medical Association has stated as a representative of many clinical doctors who believe that it is challenging to practice responsibly without these subjective patient information regarding telemedicine. Please.
So it's a really great question. And I think it's too early to know the answer yet as to what's perfect or what's optimal. But I will say it's a great time for us to explore the potential and possibilities. And as you note, the work that Livongo has begun in sending devices to people's home to pull back a clinically accurate signal is itself something new. It's something that 30 years ago we wouldn't have thought about, the ubiquity of cellular connectivity as part of a person's own healthcare self-management. But yet it's feasible from both a technology and cost perspective and a consumer usability perspective. I think that same trend is extending into many other clinical areas and conditions. And that includes the treatment of high blood pressure. It includes, of course, the monitoring of weight, which could be of import in conditions like heart failure. It includes the monitoring of heart rhythm for a variety of arrhythmias. And so I think while there's these shining examples of where the technology is already available, is being adopted by consumers, we're still in early days when we think about how that intersects with clinical practice. But I feel optimistic about how much signal can be brought in routinely with very low friction in the support of medical care. And I think that includes even those parameters that you're describing of what I would think about as the traditional parts of a physical exam. And they may not be rendered in the exact same way, but the intent is that if we can start to augment the data streams, make those available, we'll be able to identify the leading indicators that are important to bring a person in. So if you think about that being the model, that we'll be able to deploy this sort of web, in a sense, a safety net of preventative routine monitoring. It will make us much more capable of knowing when it is time to bring a person in for a physical exam or for more acute care. Ultimately, that's going to reduce cost, and it's going to deliver a better consumer experience. So that's really where I see the next big interface.
Thank you, Amar. So next question is Raphael, Medical Home. So Japan is also facing soaring medical costs and the fact that the number of the medical staff for acute phase bed is much smaller than in the other countries.
Sorry to interrupt. Before we go to that question, I'd love to throw an asterisk on what Amar shared, because I think he was spot on.
Sure.
And we face this every day with a higher acuity patient in a remote setting. We use a model that was invented by the military about 4 decades ago, which is tethered medicine. We have a lower licensed, basically a paramedic or others, nurses at the bedside who become the eyes, ears, and hands of that clinician, and they're connected with the technology. So the interim step, and I completely agree with Amar, the interim step is to have that subjective clinician at the point of care, tethered to the command center where the physicians are located, including access to all the specialists. So I wanted to add that. So I'm sorry, I interrupted you.
No. Thank you very much. Thank you for that comment. So the question for Raphael. So I think you have a lot of like a medical staff and the support team to take care of the patient at home. But what's the incentive for those staff members? And what do the family of caregiver think?
Well, the caregiver is the same caregiver as in the hospital. So the hospitalists, the ED docs, the intensivists, the nurses, it's the same identical clinicians, except they're sitting in a medical command center around the clock, caring for patients and providing oversight centrally, as opposed to having the patient there. The patient's getting very, very similar to Amar's model. It's a telemedicine model, except it's physical because it's connected to the clinicians at bedside. The clinicians love it because there is no rush. And let me describe why this is a significant advance forward. We don't believe in post-acute care. We believe a patient is sick until they're not sick anymore, which means the average length of stay for a patient in our program is between 12 and 35 days. So if you add the care they typically get in the hospital, which is 4.5 days, and the post-acute care, which can range from 12 to 20 days, we care for that patient with the same identical team until the patient's clinically stable, which means we're in no rush. So the provider of that care can spend a half hour to an hour to 2 hours with that patient because the model allows for it and the economics of the model allows for it. So it creates a lot of satisfaction, a lot of connectivity with the patient. But here's the other big difference. Because we're in the home with the patient and they're chronically or very, very acutely ill, the patient's family gets very actively engaged. And this is the first time ever that the patient's family 24/7 can contact the physician and the entire clinical team around the clock whenever they need them. If you've ever been in the hospital and you're trying to find the doctor, the attending physician, particularly off hours, that's a very challenging ordeal. So what we find is the satisfaction is extremely high. Our satisfaction scores for patients and providers are well above any bricks and mortar hospital anywhere in the world because of the increased engagement and the lack of pressure on time.
Okay, thank you very much. And this is the final question, all of the speakers. At first, Amar and Raphael, are you interested in coming to the Japanese market? Yes or no?
Yeah, I spent 3 years there back in the days when I was an engineer, and I had a good experience with both Nissan and a couple of other companies. So yeah, I'd love to come back.
How about Amar?
Absolutely. Yes.
Okay. Okay, next question, specific question to Zaif. Are you interested in collaborating with US remote medicine company, mainly focus on the Japanese market?
Absolutely. I think that's what we're here for. I think there's no reason why we should not collaborate. We definitely have to learn from each other and understand what are the differences and what are the similarities that we have in our different countries. And I think I would say there are many similarities that we share in the end, because now everything is pretty much the same everywhere. So yes, definitely would be more than happy to collaborate there.
Okay, thank you very much. Thank you for your Q&A session. Unfortunately, Dr. Peter Fitzgerald has some conflict today to join the Q&A session, the networking session. But Peter is a doctor, professor, and an entrepreneur and a venture capitalist. Peter has a very close relationship with Japan and many Japanese doctors who studied at Stanford and Peter has become a professor at Japanese medical school. So he has lots of influence. If you would like to contact him, you can find his email address in the Stanford directory by typing Peter Fitzgerald and Stanford in Google. If you don't like a cold mail, you can send me the email and I can forward. So my email address is fikeno@mac.com, fikeno@mac.com. And I would like to close this session as will be the closing remark of the first part of the discussion. There is no doubt in anyone's mind that the United States is the country most damaged by COVID-19. However, the stronger the so-called pain point, the more innovators there are in the United States to try to free us from them. Vaccine and now telemedicine and the virtual hospital have quickly become popular in society as a means of satisfying the non-contract habit posed by the corona disaster. The technology that is playing a central role in this is digital technology. I think we can learn a lot from the US, where the digital transformation of medicine is progressing rapidly due to the COVID-19. So this field will continue to change at a swift pace. So I recommend that you keep continuous watch on it. The next conference, Digital Transformation in Healthcare, will be held on May 20th in Japan and May 19th in the United States at the same time as today. Next time, we will introduce 9 starting up companies in telemedicine using data technology, mainly from Silicon Valley. All are welcome to attend. And immediately after this event today, individual networking session will be held in a separate system. Each keynote speaker will have a bilingual facilitator on standby, so please feel free to attend even if you speak only Japanese. As I said in my lecture, knowing who is more important, and I am sure you are well aware that small connection can lead to the big project in the future. I hope you will join us. Ladies and gentlemen, thank you very much for that patience.